Welcome to today's case study presentation on difficult to manage asthma. We are honored to have two distinguished experts with us. Our first presenter, Dr. Anna Sandalovsky, is a general practitioner from Stockholm and a senior researcher at the Karolinska Institute. She is also an active member of the IPCRG research leadership team, where she plays a pivotal role in advancing asthma care. Joining her is Dr. Dermot Ryan, a GP with a long-standing commitment to asthma management. He is a former chairman of the Primary Care Respiratory Society and an honorary research fellow at the University of Edinburgh. Dr. Ryan also serves on the IPCRG board, continuing to lead innovations in respiratory health. We encourage you to explore IPCRG Desktop Helper number 2, which focuses on difficult to manage asthma. This publication, developed by a team of leading asthma experts, including today's presenters, provides practical guidance specifically designed for primary care clinicians to support them in difficult-to-manage asthma cases. This desktop helper reinforces four key principles. The first one, that asthma is a manageable condition. Then, that ensuring an accurate diagnosis is an essential first step in managing asthma. Thirdly, identifying and managing comorbidities is crucial to ensuring successful outcomes for patients with difficult-to-manage asthma. And finally, conducting regular and structured reviews is a vital step to improving detection and care for those that living with difficult-to-manage asthma. And I will leave you with today's guests.
Now let's have a look at the IPCRG Desktop Helper number 2 on difficult to manage asthma. What should you check when conducting a structured review? 1. Control of asthma. 2. Adherence and inhaler technique. 3. Tobacco dependence. 4. Patient education and self-monitoring. 5. Aggravating factors and triggers. 6. Pharmacotherapy. 7. Obesity. 8. Psychological support. And 9. Consider referral for specialist assessment if not resolved. Learning objectives. At the end of this case study exercise, the healthcare professional should be able to list and recognize differential diagnosis of asthma, analyze and evaluate the impact of patient's clinical history, and appraise patient's own beliefs and preconceptions in the process of diagnostics of asthma and/or breathlessness. Plan and execute periodical reviews of patient with symptoms of breathlessness and an unclear diagnosis. Case Study 3. Elsa is concerned that her asthma is deteriorating. She has experienced some events of breathlessness and dizziness during a running race. Now, what factors might be hindering the control and treatment of this patient? And is this a case of a difficult to manage asthma? Consultation 1. Elsa is a 42-year-old mother of 2 girls, aged 6 and 8. She's married. She's a school teacher in languages. She's a never smoker and drinks 1 or 2 glasses of wine at the weekends. She's very health conscious. She's a member of a running club and runs at least 10K 3 times weekly and races in the weekends. At the first consultation, you take the patient's medical history. Elsa reports no allergies and does not have any pets at home. Her parents are well and in their late 70s. None of her close family members have asthma or allergies. She has been well throughout her life until now. Apart from childbirth, she's never had any hospital admissions. Asthma was diagnosed recently in another GP practice because she experienced breathlessness towards the end of a running race and sometimes slight dizziness after the race. According to the patient, no lung function tests have been made. Her only regular medication is her asthma medication, ICS twice daily, and she has been advised to take 2 puffs of SABA prior to exercise. She uses barrier methods of contraception. So the current presentation is that the patient has recently moved to your practice and it is her first consultation so that she can receive her asthma medications. Let's look at the steps on the desktop helper number 2 on difficult to manage asthma. 1. Control of asthma. She's concerned that her asthma is deteriorating as she's getting increasingly breathless on exertion and is having to run at a slower pace. Of note, her symptoms are not variable. She has no nocturnal symptoms and in particular has no history of cough, apart from a bad upper respiratory tract infection last winter, or wheezing even when running in the cold. 2. Tobacco. She's a non-smoker. 3. Patient education and self-monitoring. Her inhaler technique is impeccable. She has been told to increase her medication if her symptoms are not controlled, so she takes extra SABA, salbutamol, when she experiences the symptoms while running. However, despite up to 2 to 3 extra doses, she's not sure about whether salbutamol really helps. 4. Aggravating factors and triggers. She has not noted anything. In particular, she has no rhinitis. She's of a slim and athletic build. 5. Pharmacotherapy. Inhaled budesonide 0.2 mg twice a day. Inhaled salbutamol is needed, both via MDI and a spacer. 4. Adherence and inhaler technique. Perfect. 5. Obesity. Lower end of normal range of BMI. 6. Psychological support. She's feeling a loss of self-confidence as her physical performance is deteriorating, especially noticeable when she's out with her running club and when she participates in a running race. 7. Referral for specialist assessment? Not at this point. So at the first consultation, your clinical examinations and investigations. Your findings. Heart and lung sounds are normal. Pulse rate is 90. She does look a bit pale. Spirometry results were normal. Her peak flow was 450 of expected 440. Question: how would you evaluate these findings? Well, chest exam was unremarkable except for the pulse rate that is a little high for someone who is so fit. Her peak flow reading is normal for age, height, and sex. Next question. What are your next management steps? Your next steps. We decide together to check a few things and she agrees to doing serial twice daily peak flow readings and also readings 10 to 15 minutes after she's been running. A full blood count will be performed to check her eosinophil and hemoglobin levels. We agree to review with the results in 2 weeks' time.
So she comes along 2 weeks later. Her peak flow readings vary between 430 in the morning and 470 in the evenings, which is a normal range of diurnal variability, and running has no impact at all upon her peak flow readings. Her eosinophils are 100 and her hemoglobin is 7 grams per deciliter, with a hypochromic microcytic picture. In women, the normal range is 12.1 to 15.1. So what additional questions might you wish to ask this patient?
The findings, particularly of a lower hemoglobin, lead to a wider range of questions, and suggesting further clinical examination might be helpful. So on questioning, you find out she eats a balanced diet, including meat 2 or 3 times a week. She has, however, heavy periods lasting 7 to 10 days and uses 8 to 10 super tampons on most days with occasional clots. This prompts an abdominal examination which reveals a suprapubic swelling approximately the size of a 13-week pregnancy and is a bit irregular in shape. This suggests to us that we perhaps need to think about a different diagnosis.
Well, the desktop helper helps us here to look at what's going on. We look at the various components of the consultation, and starting with the key symptoms of breathlessness, chest tightening, cough and wheeze, we find the only symptom she has is breathlessness. And going back to the desktop helper on the diagnosis of asthma, we know that taking one symptom in isolation is not helpful in making a diagnosis. We also find two pieces which just do not quite fit with the diagnosis. One is the low hemoglobin, and from the history, she doesn't respond to her salbutamol, whereas breathlessness due to asthma and bronchoconstriction does tend to respond to salbutamol. Furthermore, there are a number of missing pieces. In particular, she's no wheezing. She exhibits no variability in her symptoms. The only trigger factor she has is exercise. Even cold air doesn't make a difference. She has no night symptoms. She has no coughing. So this is really something of an incomplete picture which we're seeing. So again, a low hemoglobin and no response to salbutamol do not fit this picture. So assembling the pieces that we have so far with regards to her presentation, she's a 42-year-old woman. She complains of shortness of breath on exertion and also feels tired a lot of the time. She insists that she has asthma as diagnosed by her previous doctor. She's a never smoker and apart from having had babies has never had any hospital admissions. Her main hobby and recreation is running, but she finds that this has become progressively more difficult. Her history is that she's a mother of 2 children and uses barrier contraception, making pulmonary embolus unlikely. Apart from having babies, she's not had any previous hospital admissions. She works as a language teacher and therefore unlikely to have any occupational component to her problem. In terms of her presence, she is calm and relaxed. She's breathing normally with a respiratory rate of 14. Her peak flow reading is 450, which is normal for her age and height. And her resting pulse rate is 90 beats a minute, which is regular. Her chest examination is normal, but she does look quite pale. So pieces which fit the diagnosis are the shortness of breath, the exercise symptoms, and the fatigue, but that's usually caused by night waking. Pieces which don't fit are no previous illness or antecedent factors of asthma, no wheezing, cough, no nocturnal symptoms, no chest tightness, and a normal peak flow with no symptom variability, no symptom response to salbutamol, normal diurnal variability of peak flow, slight tachycardia at rest in somebody who is so fit, and some pallor. So we need to search for a different image or a different picture puzzle. Why is she so pale? Well, one suspects anemia. In her age group, heavy periods are a frequent cause of anemia, so appropriate questions were asked. Finding that she has irregular and heavy periods, examination revealed a non-tender lower abdominal irregularly shaped tumour, which ultrasound revealed to be a fibroid. Her laboratory investigations reveal a hemoglobin of 7 with a hypochromic microcytic picture and low serum iron. Thus, she was referred to a gynecologist who performs a hysterectomy, and iron tablets are commenced with a great improvement of her asthma, that is to say, her asthma symptoms.
It's easy to be misled by some of the pictures of the jigsaw that we may have in our hands. Some pieces may be very, very similar, and it's difficult to know precisely where they fit. They have difference of shades and difference of background, or similarities of shade and background. For example, breathlessness and fatigue. Or they may have shared features, such as exercise symptoms, and again, fatigue or cough. They're common symptoms, but there are a commonality to some of these portraits: foreheads, hairs, partings,
So we need to look more carefully at those to see where they occur. And then there are faces which are very similar but are really quite different. For example, they may have normal lung function or normal eosinophil counts, but looking at them, their breathing patterns may be different, and therein lies a clue to the diagnosis. So thinking about the pieces of the jigsaw, there are those which may mimic asthma symptoms, and there are those which may coexist with asthma, and there are pieces which may worsen asthma symptoms. So it's this combination of pieces put together which helps us to make the picture. You conclude that her breathlessness is mostly due to anemia caused by menorrhagia and not so much her asthma. So what would your next management steps be?
So your next management steps are: you decide to reduce her inhaled medication gradually while monitoring her peak flow readings. You commence her on iron tablets and refer her to a gynecologist. And you ask her to come back for a review after 3 to 4 months. 3 months later, at consultation number 3, clinical examination and investigations. Hemoglobin is now 12.5 with a normocytic picture. Elsa feels generally more energetic and reports no more dizziness. However, she still feels breathlessness while running, particularly when she runs races. She then may take extra salbutamol, but is still unsure if it really helps. Question: what is your conclusion so far, and what will be your next steps? A new review, keep in mind the previous steps. Ensure that the diagnosis is correct, find and manage comorbidities, and conduct a structured review focusing on these elements from the IPCRG Desktop Helper number 2 on difficult to manage asthma. 1. Control of asthma. 2. Tobacco dependence. 3. Patient education and self-monitoring. 4. Aggravating factors and triggers. 5. Pharmacotherapy. 6. Adherence and inhaler technique. 7. Obesity. 8. Psychological support. And 9. Referral for specialist assessment. Your management steps at this point. You suspect ELO or exercise-induced laryngeal obstruction or dysfunctional breathing, and start out by referring the patient to an ENT unit that performs ELO investigations. You also question the accuracy of asthma diagnosis. You decide to step down the medication. In fact, you tell the patient to stop taking her inhalers altogether while monitoring her peak flow readings. You plan for a follow-up when the ENT consultation is done to review a possible asthma worsening. 1 month later, consultation number 4. The ENT investigation was normal. The patient does not report any worsening of breathlessness or what she considers as asthma symptoms, despite not taking any ICS or SABA. Her peak flow readings are the same as before. You perform a spirometry again, and it is almost identical to the previous one, almost 5 months earlier, when the patient had an ongoing asthma medication. Question now: what is your conclusion so far, and what will be your next steps? At last, you are at the final diagnosis for Elsa. You conclude that she suffers from dysfunctional breathing. Dysfunctional breathing is a respiratory condition characterized by breathing patterns, typically shallow rapid breathing and speaking short sentences, that occur either in the absence of concurrent diseases or secondary to cardiopulmonary diseases. Although the primary symptom is often dyspnea or perceived difficulty in breathing, dysfunctional breathing is also associated with non-respiratory symptoms such as dizziness and paresthesia and palpitations. Dysfunctional breathing has been identified across all ages with a prevalence of approximately 9.5% in adults and more common in females. Among individuals with asthma, dysfunctional breathing is found concomitantly in a third of women and a fifth of men. Dysfunctional breathing is often underdiagnosed or misdiagnosed, given the similarity of its associated symptoms, such as dyspnea, tachycardia, and dizziness, to those of other common cardiopulmonary diseases, such as COPD and asthma. So you conclude that Elsa does not have asthma. You explain clearly to Elsa that she does not have asthma and inform her about dysfunctional breathing. You agree on a referral to a respiratory physiotherapist or speech therapist who is specifically interested in respiratory diseases to help patient manage this condition. So let's summarize this case. First, ensure that a pre-existing diagnosis of asthma is correct. Always ask yourself, does my patient really have asthma? A correct asthma diagnosis is based on a thorough review of clinical history, and the diagnostic probability of asthma is significantly increased if you use a lung function test. As the airway obstruction in asthma is variable, a normal spirometry does not rule out asthma. Commonly, spirometry is performed when the patient is controlled or asymptomatic, which leads often to a false negative result. Be aware of that. And don't be misled. An open-minded, broad approach to assessment of breathlessness in a patient with pre-existing asthma diagnosis is crucially important. Use always a structured interview and appropriate diagnostic tests to investigate whether patient's symptoms are caused by asthma, comorbidities causing similar symptoms, or maybe other conditions worsening asthma or mimicking asthma symptoms. So review a patient with breathlessness periodically and continue with reviewing until the reasons for their symptoms have been found, treated, and improved. And lastly, if you want to learn more about difficult to manage asthma, please check out our QR code on the desktop helper on the subject.